Testing 1 2 1 2 test 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 1 2.
start.
Yes. When you're ready, just introduce yourself.
Go ahead and turn that, put
You
that
may have
overhead
to
on.
speak a little bit loud at first to get their attention.
Hello? Hello, can everyone hear me?
Maybe you turn it up a little bit.
Turn.
Maybe you might go there and turn it up a bit. You don't, just, you can leave that on, there's nothing to do with it.
Oh, okay.
You'll have to turn it up a little bit on the other side.
Hello? Yeah, I think this is probably good. Can everybody hear me? No, maybe not. I can also move this a little closer. How is that? Is that good? Is that any better? Doesn't sound like it. Hello? Everyone with me now? Huh? Okay, so this is as loud as it can go. Okay, all right, so I just need to project. All right. All right, so I'm going to get started. Can everybody hear me okay? Yes, okay, great. So thank you very much to Ascension and St. Vincent's for the invitation to speak to you all today about heart failure. So I'm going to start by telling you all a little bit about myself. My name is Joanna Jolly. I'm originally from the Washington, D.C. area in Maryland. I did my medical school and residency at Georgetown. Then I came to UAB for my cardiology fellowship, and that's where I fell in love with hemodynamics and heart failure. I finished my training in advanced heart failure and transplant cardiology at the Brigham and Women's Hospital in Boston, and I've been faculty at UAB specializing in heart failure and pulmonary hypertension since then. So my objectives for this talk are to illustrate the cornerstones of chronic heart failure management, as well as the clinical management of acutely decompensated heart failure. So we'll finish the hour by discussing when it is appropriate to refer a patient for consideration of advanced therapies, such as VAD or ventricular assist device or transplant. So we're going to start with a case. This is a Mr. VF who was referred for increasing dyspnea with minimal exertion and fatigue at work. He's 59 with a past medical history of hypertension, chronic kidney disease, and GERD. He's a non-smoker but has an occasional beer watching Alabama football games. And he works at a factory near his home in Oxford, Alabama. His father died of colon cancer, his mom from heart failure. He's got 2 children, both adult children, and both are healthy. He's on hydrochlorothiazide and amlodipine for his hypertension and a proton pump inhibitor for his GERD. So his vitals are listed up there. He's got a heart rate of 90, a blood pressure of 131/85. His labs are significant for a microcytic anemia. He's got a slightly elevated but overall stable creatinine, slight hyponatremia, borderline low potassium, and an elevated BNP, which I always describe to patients as a marker of stretch or strain on the heart. The physical exam is consistent with compensated heart failure and mild volume overload. He's got elevated jugular venous pressure, no gallops. He's got a laterally displaced point of maximal impulse, or PMI, which suggests an enlarged left ventricle and mild lower extremity edema. He appears well perfused because he's warm. His chest x-ray shows mild cardiomegaly, and an EKG is done, and that's actually a very important part of evaluating heart failure patients. It can give you a lot of important information about their current hemodynamic status, the potential etiology of their heart failure, such as if you see Q waves, suggesting prior ischemic heart disease. And it can sometimes give a clue that a specific kind of therapy may be very beneficial in certain patients. And I'm specifically talking about left bundle branch block and how cardiac resynchronization therapy is a treatment for that. Of course, the echocardiogram is usually diagnostic, so he gets an echocardiogram today. So I'm not sure how many people in this room are familiar with echocardiograms, so I'm going to include a very normal looking echocardiogram on the left here. So you can first see what normal systole and diastole look like on ultrasound. So you can kind of commit that to memory. I'm going to show you what the echocardiogram of Mr. VF looks like. So what should stand out to you on his echocardiogram is that there's both systolic and diastolic dysfunction. In contrast to the view on the left, the one on the right happens to be a 5-chamber view, so it also shows his aortic valve if you're wondering what's in the middle of the screen there, opening and closing. The cornerstone of medical therapy for systolic heart failure is neurohormonal antagonism. So we block the angiotensin-renin system and inhibit neprilysin with ARBs, ARNIs, such as Entresto, and ACE inhibitors. I often start patients who are just diagnosed on losartan, so I don't have to bother with that washout period that ACE inhibitors require when I switch them. Hopefully, I'm able to switch them to Entresto. So we block the sympathetic nervous system with beta blockers like carvedilol and long-acting metoprolol. And I add a mineralocorticoid antagonist, such as spironolactone or eplerenone, as soon as I can, making sure to check a BMP about a week later to ensure that they've tolerated it from a renal and potassium perspective. And especially for my African American patients, I look for opportunities to add hydralazine and long-acting nitrate combination. So everything this cocktail of medical therapy for heart failure has in common is afterload reduction. So I'm going to use that term interchangeably with systemic vasodilation. The concept is that we're reducing peripheral vasoconstriction and allowing the native heart to pump more volume into the circulation with each beat. So I put this timeline together to show that the strength of evidence for vasodilation and afterload reduction in patients with systolic heart failure goes back 3 decades. So the first trial there, if you can see it, is all the way back in the late 1980s. So the highlighted studies all demonstrated a mortality or heart failure hospitalization benefit, or both, in the heart failure population. So this is really to emphasize just how important and effective the concept of afterload reduction is in managing patients with chronic stable heart failure. You can truly extend life and improve quality of life by keeping people out of the hospital with these medications. So on the heels of this research, heart failure registries spanning from the 2002 to Get With the Guidelines registry in 2011 show that there's been appropriately an increased utilization in guideline-directed medical therapy for chronic heart failure. We're now 9 years beyond 2011, but even back then in 2011, you can see on the far right column, most patients eligible were in fact receiving beta blockers and RAS inhibition. And I think that that's great. It's also really interesting to think what effect chronic use of neurohormonal blockade might have on patients admitted now with acutely decompensated heart failure. So I will tell you what I've observed. Many hospitalized patients now are requiring inotropes in order to be diuresed to euvolemia. As a fellow, I had the opportunity to see this done at Cleveland Clinic, at the Brigham, and here at UAB as well. Once a patient is fully diuresed, many attending physicians will try to restart guideline-directed medical therapy or some sort of afterload reduction, meaning they'll be treating them with dobutamine and then switch them over to captopril, or treating them with dobutamine and then switch them to hydralazine. In very, very few cases that works, but in many other cases the blood pressure bottoms out and the patient becomes symptomatic, lightheaded, more fatigued, etc. So this schematic represents the relationship of acute decompensations to the progression of chronic heart failure and myocardial function over time. With each decompensation, patients stabilize at a lower functional state. I believe that guideline-directed medical therapy has lengthened the natural history of the disease and improved quality of life, such that when decompensation does occur in the current era, patients seem to be much further along in the natural history of their disease. The section that I've highlighted up there represents truly end-stage disease, which is characterized by systemic vasoplegia or poor vascular tone. Initiating guideline-directed medical therapy at this point could be disastrous. So the phenotype of acute decompensated heart failure has changed. The population we're often treating in the hospital now demonstrates a pathophysiology that prompts discontinuation of guideline-directed medical therapy instead of being able to titrate it up. So I want you all to start thinking about discontinuation of guideline-directed medical therapy as a hinge point in the natural history of a patient's heart failure. So for clinicians, this may be an opportunity to consider advanced therapies, including transplant, LVAD, or home inotropes. Regardless, it's a moment that should prompt a frank discussion about disease severity, poor prognosis, and should ensure really close follow-up. Regarding the epidemiologic impact of heart failure, it's staggering. The bottom line is that heart failure is a huge public health problem, and it's the reason for a huge number of hospitalizations every year, which rack up a huge total cost of inpatient care, expected to be $53 billion in the US alone by 2030. These are risk factors associated with post-discharge death or rehospitalization following a heart failure exacerbation, and includes renal dysfunction, recent heart failure hospitalizations, mechanical ventilation, other comorbidities, etc. The vast majority of patients, when they presented an acutely decompensated heart failure, complained of dyspnea. Notice that the majority of patients in registries from the early 2000s presented with systolic blood pressure that was higher rather than lower. This points again to my theory that patients hospitalized with acute decompensations were once upon a time less sick than they are now. So it's noteworthy that although excess volume drives many of the symptoms of acute heart failure, not all present with symptoms of dyspnea. The reason for this may be enhanced lymphatic drainage from the interstitium in the lungs. This is why some people may appear completely overloaded on exam and yet not have a single rail or crackle when you listen to their lungs. So absence of crackles may actually give you a sense then of chronicity of their disease, similar to how a dilated left ventricle can give you a sense of the chronicity of their disease. So acute decompensations are rarely new presentations of heart failure. The majority live with chronic heart failure and some amount of baseline symptoms. Mean age of patients hospitalized with heart failure is 75, and an equal number have preserved EF as have reduced EF, and of course comorbidities are common. It's really important to identify triggers for the decompensation event or amplifiers of symptoms such as ischemic disease or anything that can cause hypoxemia. Triggers can also include arrhythmias, which can be primary triggering events or secondary amplifiers. We see this often with AFib, for instance. If you can adequately diurese them many times, although of course not all the time, they'll convert back to normal sinus rhythm on their own. Obviously, volume overload is a big one. We often blame patients and attribute their failing health to sins of dietary indiscretion. But of course, don't forget that their kidneys are working against them. They'll hold on to sodium and water more than normal people do due to unmitigated neurohormonal activation. Much less discussed, but undeniably relevant, is the role of venous capacitance vessels in the role of in sudden decompensations. So this is a schematic of the fast and slow mechanisms of circulatory congestion. The renin-angiotensin and aldosterone systems considered slow, that's on the right. But any minor precipitant can bring about sympathetic activation, which can immediately mobilize a very vast venous reservoir and lead to increased effective circulatory volume. Remember that blood in the venous system accounts for 70% of total body volume, and veins have 5 times the adrenergic input than what's found in arteries. Thus, for a given sympathetic stimulus, veins will have a much more profound sympathetic response. So this may be further proof that the venous reservoir contributes to acute decompensations. So you'll see on the x-axis there that 30 days prior to a hospitalization, mean body weight diverges leading up to a heart failure hospitalization compared to a hospitalization for another reason. But if you look at the y-axis, average weight gain prior to acute decompensation is really only about 2 or 3 pounds. So acute decompensations may have to do with distribution of volume within the body as well as total body volume. So implanted intercardiac monitoring can give real-time feedback on filling pressures. So this is the CardioMEMS system implanted into the pulmonary artery via right heart catheterization. With daily monitoring and acting on pressure readings and trends, the group with CardioMEMS had a significant reduction in the combined endpoint of heart failure hospitalizations or mortality. This device was FDA approved in 2014, and since then, the post-approval study has shown further improvement with real-world use. The key, of course, is that someone looks at these pressures on a regular basis and acts on them, adjusts medications, adjusts diuretics, adjusts afterload reduction, etc. So we're going to pause for a moment and go through another case. This time, Miss AF presents to the emergency department with worsening dyspnea, and she has jugular venous distension and peripheral edema. Notice the narrow pulse pressure in her blood pressure, suggesting advanced heart failure, and the tachycardia is the body's way of maintaining cardiac output. So Miss AF is sitting upright to breathe comfortably, and her chest x-ray shows pulmonary edema. So your first drug of choice is likely Lasix. So per the guidelines, it's recommended to give diuretics right away. Don't be afraid to give a high dose, at least equivalent, but we usually give quite a bit more than their chronic PO regimen equivalent. You can give either bolus dosing or drip. The important thing is to check for a timely response. We use strict monitoring of ins and outs, at least twice a day, and then daily weights. If you're unhappy with the response to your initial dose, give a higher dose, plus or minus a thiazide booster. So let's say that Miss AF gets IV diuresis and does not respond adequately. So there's a question regarding her cardiac output, so we schedule her for a right heart catheterization. A right heart cath is performed by measuring pressures in sequential chambers from the right atrium to the right ventricle to the pulmonary artery. The catheter floats along this pathway of blood with the help of the inflated balloon, which helps carry it. When the balloon wedges firmly in a small branch artery of the pulmonary artery, the distal pressure tip, which is also gives a pressure called the pulmonary capillary wedge pressure, gives an estimation of the left atrial filling pressure, which gives us a sense of the function of the left side of the heart. So here are her numbers. Right atrial pressure is 12. Remember that a normal right atrial pressure is 5, so 12 is actually more than twice the normal value. PA pressure is 60/30 diastolic with a mean pressure of 40. A mean PA pressure of 40 suggests that she has moderate pulmonary hypertension. So then we look at the pulmonary capillary wedge pressure. The wedge pressure is 30, and that's high, especially considering the fact that the left atrial pressure should be around 12. Remember that left atrial pressure is really a surrogate for left ventricular pressure, which is what we actually really want to know. So except for significant mitral valvular disease or left atrial noncompliance, left atrial pressure does approximate filling pressure of the LV or the left ventricular end diastolic pressure. And also what you can tell about the moderate pulmonary hypertension, if you calculate the transpulmonary gradient, so 40 subtract 30, you get 10. It's less than 12, which is roughly our cutoff for what's pulmonary hypertension due to left heart disease versus the other types. In her case, it's due to left heart disease. So a right atrial pressure to pulmonary capillary wedge pressure ratio of 12/30 or 0.4 suggests that aside from there being excess preload on board or excess total intravascular volume, the LV does seem to be failing out of proportion to the RV failing. Once RV pressure exceeds about 2/3 of LV pressure, you should have a very high suspicion for biventricular failure or right side predominant disease. This is really important implications not only for the etiology of this person's heart failure, of course, but for candidacy for advanced therapies. We very, very rarely and try to avoid putting an LVAD or left ventricular assist device in patients who have severe right ventricular disease as well, because you need a functioning right ventricle to fill the left ventricle enough to fill the pump. So to summarize her right heart cath so far, Miss AF's intravascular pressures are very high. Her left ventricle is struggling to fill. So we perform thermodilution or oximetry of a sample of mixed pulmonary artery blood. I'm describing the Fick method of calculating cardiac output. And we find that her cardiac output is 3 liters per minute. We divide that by her body surface area of 2 to get 1.5 liters per minute per meter squared, which suggests that her LV is also struggling to provide adequate cardiac output. Normal cardiac index, for your reference, should be about 2.5. So the next thing to consider is the systemic vascular resistance, which is calculated by a mean arterial pressure minus the right atrial pressure divided by cardiac output multiplied by 80 to get us to convert it to dynes. So here it is with the actual numbers. And we're left with 2080. This is very elevated, normals around 1200. An elevated SVR suggests that afterload reduction should and will improve her cardiac output. Now, we don't have an echo yet on Miss AF, but let's hope that she has a dilated left ventricle. Remember that a dilated ventricle is much more likely to experience a change in stroke volume if you acutely decrease afterload compared to a hypertrophied ventricle with a small cavity. So this diagram shows a normal heart in the middle. The difference between the 2 vertical lines in each of these pressure volume curves represents stroke volume or ejection fraction. On the right side, a ventricle dilates until it's constricted by a rigid pericardium, shifting its end diastolic pressure-volume relationship up and to the right. A thick, muscly LV, on the other hand, and on the left side, has a noticeably narrower stroke volume at baseline. So the red lines up there represent afterload, which is related to end diastolic pressure-volume relationship. So let's see what happens when we reduce afterload by giving either nitroprusside or hydralazine. So you can clearly see that stroke volume in blue is improved more in the dilated ventricle than in the hypertrophied ventricle. So let me just show that again. So this is how they're presenting. You give afterload reduction. You can improve stroke volume much more impressively in a dilated ventricle than you can in a concentric hypertrophied ventricle. So in this Cleveland Clinic study, patients treated with nitroprusside titrated to a MAP of 65 to 70 experienced greater improvement in hemodynamics and lower all-cause mortality. So this was their method. Once the mean arterial pressure goal of 65 to 70 was achieved, which occurred in most patients within 24 hours, nitroprusside was then weaned while isosorbide dinitrate and or hydralazine was up titrated. The exact way was left up to the treating physician, but this was their published protocol. Total duration of nitroprusside infusion ranged 24 to 72 hours, so really not that long. Creatinine was unchanged from admission to discharge. Blood sampling for thiocyanate toxicity was not routinely performed, and they didn't notice any patients had any signs of toxicity. So back to Miss AF. So not only did she get furosemide, she also got nitroprusside. She diuresed to euvolemia and was able to be discharged home. She also got isosorbide dinitrate and hydralazine to switch her off of nitroprusside. So this is a nice segue to a discussion on medical management for acute decompensated heart failure. So we're including the 2013 guidelines as well as the focused updates published in recent years. No talk on acute decompensated heart failure would be complete without showing this table. So both dimensions of this table rely heavily upon a very careful, accurate physical exam. So horizontally is volume status. The left column represents no volume overload, whereas the right column represents volume overload. Vertically is perfusion. So the top row is warm, meaning the body's organs are all receiving adequate blood flow. The bottom row is for cold, meaning the body's organs are not receiving adequate blood flow. So we already discussed diuretics and afterload reduction acutely. So what do we do about guideline-directed medical therapy when a chronic heart failure patient presents volume overloaded and dyspneic? So the 2013 guidelines are very clear. If no hemodynamic instability or other contraindications exist, they recommend continuing the home regimen. But due to marginal blood pressure or slight acute kidney injury, so I'm often finding I have to suspend guideline-directed medical therapy in these patients. This is a secondary analysis of Get With the Guidelines Heart Failure Registry, which showed that if you were able to start a patient on an ACE inhibitor or ARB or continue their present therapy during decompensation hospitalization, survival was better compared to patients in whom you could not start that therapy or in whom you had to discontinue it for whatever reason. What about beta blockers? So after you've achieved euvolemia and transition from IV to PO, diuretics and vasodilators, guidelines recommend starting low-dose beta blocker in stable patients. My personal practice, however, is that if inotropic support was needed, I rarely start a beta blocker while they're still in the hospital. More often, I start it at their first follow-up visit, if at all. What does it mean if you have to discontinue a patient's beta blocker? So this is a post hoc analysis that showed that reducing beta blocker dose was no different than stopping it entirely. Patients whose beta blocker had to be reduced or discontinued entirely had much higher mortality than those whose beta blocker dose was unchanged. This is unadjusted data, meaning it does not account for markers of disease severity. So I interpret this to mean that if I have been taking care of a patient with heart failure and I've finally gotten them stabilized and feeling better off their home ACE inhibitor and beta blocker, re-challenging them with guideline-directed medical therapy may be reasonable, and if I try to do it, it will be at their follow-up visit. But if their hemodynamics and symptoms do not tolerate it, it's important to have a conversation with them that their disease is progressing, and in 2 years, projected survival is probably around 50%. If there is no symptomatic hypotension, you can consider using IV vasodilators as an adjunct to diuresis, especially if you have invasive hemodynamic data from a right heart cath that shows or confirms an elevated SVR. So I'm going to spend just a few minutes on the focused update published in 2017, which incorporates many of the recommendations from the 2016 update. But there's not a whole lot in either that relates specifically to management of acute decompensations. So I have 2 slides about patients with heart failure with preserved ejection fraction, or HFpEF. Basically, the 2013 guidelines recommend controlling hypertension, relieving symptoms of congestion with diuresis, and then treating underlying or comorbid conditions such as coronary disease and AFib. The update from 2017 confirms all those recs remain current, with one new point which incorporates new randomized control trial data. Specifically, geographical peculiarities in the results of TOPCAT, which was a study that investigated spironolactone in patients with heart failure with preserved ejection fraction, led investigators to do a sub-analysis which showed that even though TOPCAT itself was null, spironolactone did reduce heart failure hospitalizations in American patients who were with heart failure with preserved ejection fraction, but not the Russian, Georgian demographic. So this is why the guidelines included this update. So back to heart failure with reduced ejection fraction. Although it's common, at least for me in my practice, to use milrinone or dobutamine in the hospital to aid diuresis, there have been no randomized control trials to recommend their use for this particular indication. Every trial done looking at outcomes after treatment with dobutamine or milrinone have shown an association with increased adverse events. This was a randomized control trial comparing milrinone versus placebo in patients admitted with acute exacerbation. The authors clearly state that the patients did not require inotropic therapy. And of course, they found adverse events mainly related to hypotension and arrhythmias that were significantly more common in the group treated with milrinone. I would be very curious to repeat the study in patients who do require inotropic support due to poor cardiac output, worsening end organ function, or failure to diurese. Those are all patients that you might consider inotropic support. I suspect that in those patients, milrinone at least may shorten time to euvolemia. So before hospital discharge and at every follow-up visit, initiation and optimization of guideline-directed medical therapy should be addressed. This requires a physical exam, paying attention to perfusion and volume status, and eliciting symptoms and functional status. You should also try to identify any significant barriers to care or support limitations that may lead to a bounce back. You should feel comfortable that their renal function and electrolytes are stable on their current regimen. And of course, make sure other comorbid conditions are being addressed. Anemia, obstructive sleep apnea, obesity, diabetes, etc. Addressing all of those things could contribute to symptomatic improvement. Lastly, providing education about their disease, what the medications do to treat their disease, and what things they can do to take an active role in their own health are all really important components. And if you do suspect that they're truly end stage, a referral either to UAB for advanced therapies or to palliative care may be worthwhile, or both. Lastly, multidisciplinary management is recommended, especially for those who are high risk for rehospitalization. So we're going to finish up with our patient, Mr. VF, who's just been diagnosed with new heart failure. So first of all, we are going to make sure his comorbidities are well controlled. We will recommend he stop alcohol entirely for its direct toxic effect to the myocardium, and congratulate his avoidance of tobacco and other substances. Given his suspicious family history and implications it has for his children, we will offer genetic testing. We have a relationship with a company that any new heart failure patient typically will get a genetic cardiomyopathy screening panel to look for typical inherited variants that might be the cause for their cardiomyopathy. If one's identified, first-degree family members can be tested for that single gene itself to better understand their risk. We'll stop his hydrochlorothiazide and amlodipine, and instead we're going to start a beta blocker and ARB, and we'll bring him back frequently to continue to optimize these medications, maybe switch him to Entresto, maybe add spironolactone, maybe add hydralazine or ISDN. We will have him aim for a heart rate of 60 to 80 beats per minute resting and a systolic blood pressure of 100 to 120. We're going to continue to up-titrate meds based on these parameters, and I have patients get a blood pressure cuff that has a heart rate monitor, so it kind of puts them in charge of hitting these hemodynamic targets. He has microcytic anemia, which is often related to iron deficiency. So if we confirm that that's the case with full iron panel, then I have a very low threshold to prescribe IV iron infusions. With guideline-directed medical therapy, and especially if maintenance diuretics are needed, we'll have to watch his electrolytes closely. We can consider addition of polyunsaturated fatty acids, which, like iron supplementation, improves quality of life measures, but not mortality. And we'll examine him with close attention to volume status and adequacy of perfusion. Remember that a new diagnosis of heart failure warrants an ischemic workup. We have many non-invasive modalities to choose from now, from echo to nuclear to MRI. We can have patients achieve a stress state for any of these imaging modalities physiologically by getting them on a treadmill or via chemical simulation. The gold standard, of course, remains coronary angiogram, and the benefit of that is it offers an opportunity for a right heart cath at the same time, which, as you can see, will be very helpful for better defining their heart failure and their hemodynamics. Also, curing heart failure is a lot more fun than managing it chronically, so look for reversible causes and definitely educate patients about their heart failure. At the beginning, when we're first diagnosing someone with heart failure or first managing them in clinic, we see them back very frequently until their medical regimen and symptoms are stable. please don't forget to repeat an echocardiogram after a few months of guideline-directed medical therapy to see if they'll need a referral to an electrophysiologist for placement of a ICD for primary prophylaxis. And lastly, if Mr. VF's symptoms do not improve back to NYHA class 1 or 2, my personal practice is to risk stratify right then, which seems early, but it's to risk stratify with a right heart cath and metabolic stress test to help guide medical optimization or whether or not it may be time to actually evaluate for advanced therapies. So speaking of advanced therapies, this is probably one of the most important slides I'm going to show you today. So remember, when patients on good guideline-directed medical therapy start decompensating, they are usually end stage. That's, of course, if they have been taking their medications, if they have been on optimized doses. So I believe we have less time and much narrower of a window in which we can help them. So we all have to work together and we have to act quickly. So these are some red flags that heart failure has become end stage and should prompt a referral, or at least thinking about it. So you know these symptoms well, so if you start noticing or start eliciting a history that they're having functional decline or worsening symptoms, that should be a red flag. If they start having a lot more ICD shocks or syncope, if, again, I've mentioned this a number of times, if you're noticing that you have to reduce doses or discontinue any of their previously tolerated guideline-directed medical therapy, that's a red flag. If you start seeing on routine lab work signs of end organ dysfunction, if they have evidence of refractory angina or refractory life-threatening arrhythmia, if you consider them now inotrope dependent, or you just see a change in their hospitalization pattern. Someone you were following for years had been admitted to the hospital once every 1 or 2 years, now suddenly has been in the hospital 3 times in the last 6 months. That's a significant change and a reason for referring. So any person referred to us for end-stage heart failure is considered for both transplant and LVAD, or left ventricular assist device. Sometimes patients ineligible for transplant may still be candidates for LVAD. Regardless, there are a few things worth mentioning here that may threaten their candidacy. So we're pretty strict on demonstrating freedom from substance abuse. Obesity is a common barrier here, especially here in the South. Of course, specifically a BMI greater than 30 will disqualify patients from transplant. We're a little bit more flexible for VAD patients, but not too much more. They definitely do have worse outcomes. All comorbidities will have to be evaluated very carefully in order to better understand peri and post-operative risk, specifically ones that are common and ones that can be disqualifying: diabetes, peripheral vascular disease, chronic kidney disease, COPD, malnutrition. And lastly, patients are carefully assessed by members of our multidisciplinary team to assess the quality of their social support and their personal ability to cope and thrive, both of which we have seen are essential components for a successful outcome. All right, that concludes my talk on heart failure. Thank you very much for your attention. And again, thanks for the invitation to speak to you all today. Please make note of my contact information. I'm happy to be a resource to any of you at any time, and I'm happy to take some questions.
I was involved in the late 80s with a study with the use of inotropes for congestive heart failure, and they had a better quality of life, better outcomes in terms of quality of life, but the endpoint mortality was higher. Has that changed with the advent of the new drugs?
I think it has. Like we are managing patients on home inotropes now that have been living with them for a year or two. Now that seems to probably still be a little bit more the exception than the rule, but I do think that there's an opportunity to do some studies that actually show the benefit of them in certain patients who otherwise don't really have another option for transplant or VAD. So I think there's definitely a lack of literature out there that does prove that point, but that's my observation as well.
Do you have an upper limit of age for cardiac transplant?
That's a great question. I think, so there's not like a hard and fast age that we absolutely disqualify. When I was up doing my fellowship in Boston, I think we heard Boston University had transplanted someone, I think 78, if I'm remembering correctly, which is impressively old for getting a transplant, but chronologically this person was still like, running marathons. And so I think chronologic age is definitely more important than physiologic age, biologic age, like how someone actually is and how their functional status is a little bit more important than actual chronologic age. We tend to stop really thinking about it probably right around 70, and even high 60s, we have to be pretty convinced someone would do very well.
What's the wait time usually on a transplant?
That really depends. The question is, what is the wait time on heart transplant? And that can vary quite a bit. There's a recent change in the allocation system, heart transplant allocation system, in order to make sure patients who are sicker have less time to wait. And I think those sort of results on whether or not that allocation change has achieved that is they're sort of coming out now-ish. I would say it depends on other things. Depends on the size of the person who's receiving the transplant. So the bigger you are, the smaller your pool of donors, because you have to have a heart that can pump blood through a big body. Blood type can also limit you as well. If you're a recipient on a wait list waiting for a donor organ and you're a blood type O, that really limits your the number of organs you can receive as well. So if you are a small, very favorable blood type and you're very, very sick, your wait time is going to be on the order of days to weeks. That's assuming you're sick enough to be in the hospital, compared to someone who's sick enough to be on the transplant list, but maybe okay to be living at home, big, tall, also blood type O, they can wait for years, and some people never receive an organ. So, yep.
So with the new studies, even like with the ticagrelor in non-diabetic patients reducing their risk of congestive heart failure, where do you see kind of the entry of the SGLT2s into the guidelines?
That's a good question. So, I was really happy to see that a lot of those studies have had such a dramatic outcome benefit in patients with heart failure. I think there's definitely some cardiologists that I work with, colleagues that are much more free with prescribing those medications themselves. I typically don't, and kind of my group tends to not. We still sort of defer to endocrinology to start that, but we'll often sort of want that to be a consideration, especially if diabetes is a not well-controlled comorbidity. I think there's definitely a lot more opportunity to get that medication initiated and part of the regimen. Probably the next set of guidelines, I'm sure that will be a much bigger part. Anything else? All right. Thank you all very much.